Good afternoon, everybody, or still good morning, depending on what part of the country that you're in. My name is Liam. I'm our senior account manager here at Compliancy Group, and just wanted to very quickly thank you for joining us. Today, we're going to be talking specifically about MIPS as far as the 2019 requirements, and going a little bit deeper into this topic than we as a company normally would as HIPAA experts. We actually have a special guest today. Belinda Holmes is going to be acting as kind of our subject matter expert on the MIPS side of things. She's a healthcare management consultant and overall revenue cycle expert, 25 years of experience within healthcare and inside of this field. Majority of the webinar today is going to be handled by her. I'm about to pass it over to her in just a minute. Do keep in mind that there is the question and answer feature for the GoToMeeting, so do not hesitate at any point in time if you have any questions throughout the webinar to go ahead and ask them in that question and answer box within the GoToMeeting. We're going to have some time for Q&A at the end. So with that said, Belinda, are you still with us?
I am.
Awesome. I'm going to go ahead and pass it over to you here and let you do what you do best. All right. So go ahead and take over.
Thank you, Liam. Good afternoon. So good of you all to join us. I am going to be going over MIPS. And the good news I have to share with you is that we have MIPS 2019, but the final physician fee schedule rule for 2020 was just released late last week. So I have hot off the press news for 2020 as well. Wasn't sure if I was going to have that or not, but CMS came through. So we are going to discuss anything and everything for the basics of MIPS if you haven't started or if you've been doing it all year, the things where we see people trip up, and how to get through the end of 19, a test in 20. We will also be talking about then how 20 is going to look compared to 19. And I think I know most of you, and I am a certified coder and a certified compliance professional. I run both the consulting side of healthcare management consulting as well as our online training portal, mymeducator.com. And we are going to look at MIPS today. So basically, this is a graphic of where we've started and where we're headed. In 2017, the potential penalties and the potential bonuses were a -4 if you were penalized, up to a +4%. That has titrated up every year. So in 2018, you had a total of 10% at risk, 5% potential penalty, up to a 5% potential bonus. 2019 for this year is 7%. And so if you do nothing, you are guaranteed to get a -7% adjustment from Medicare, which means that you will be recouping 93% of Medicare instead of 100% of Medicare for everything that you bill. The upside is if you do spectacularly well with the program, you can get up to a 7% and more, and we'll talk about that a little bit later, bonus, so that instead of 100% of Medicare, you could have 103, 105, 107% of Medicare coming in based on your scores this year. In 2020, that gap continues to grow, and it's a total of an 18% spread. You can get anything from a 9% decrease in Medicare, so that you're at 91% of Medicare, all the way up to 109% of Medicare or more. Again, just to review, that 7% that's at risk for 2019 is applied in 2020. I know that still sounds like a ways off. However, it is just about a year away. Someone just said to me, we are in the last 60 days of the teens. And I was shocked to think about that. But we are headed full speed into 2020. And therefore, 2021, when that big 7% penalty could possibly be applied, is really just a year away. Your 2020 is, again, the same 9%. That would be applied in 2022, not that far away. Exceptional performers, and when I said before that it's possible you could get more than that 7 or 9% bump up than is what is offered on the baseline, that is reserved for what they term exceptional performers, and that could be up to as much as 10% on top of that 7 or 9%, depending on the year you're looking at. Now, that is hard to come by, and you really have to be in the top stratosphere of those numbers, keeping in mind that this is a national program, as Medicare is, and so every provider is competing for that top money. So you're competing against the Cleveland clinics and the top scorers in the country. MIPS is designed to be budget neutral, and that means that for every incentive that's awarded, for every percentage point above Medicare that's awarded, someone else has to have a penalty because it's budget neutral. Another reason to report MIPS is that your scores appear on the Physician Compare website. This is publicly available for anyone and everyone, patients, consumers, and otherwise. I have a little screenshot here. This is one of several databases that the Physician Compare website offers. It goes both by groups and organization. It also goes all the way down to the level of individual physician and practitioner. So someone can go in, they can see, again, this is more of a summary report, but they can see exactly who you are, if you participated, and if you did exactly what you scored in each category and even on each measure. So that with CMS hopes that with this report that they are giving consumers more information to select better by quality measure standards providers. So basically, if you're scoring low, it can look like to a potential patient or consumer that your services are not as high quality as someone else's. So that's why they post this. So if nothing else matters to you, maybe the PR does, this is out there for consumption. So this is a dashboard, a speedometer, if you will, for the 2019 payment adjustment. Again, we have a total of 7% negative penalty at risk. So if you score between 0 and 7.5 points, you will be assessed a 7% penalty on all your Medicare payments. And the reason the 7.5 is that is 1/4 of the performance threshold, which is 30. So for 2019, the performance threshold for all providers, unless you fall into an exemption, and again, we'll talk about that in a little bit, is 30 points. So to avoid penalties, you must score at least 30 points, 30 MIPS points, or qualify for appropriate exemptions. If you score between 7.5 and 30, then, or 29.99, then you may have a smaller penalty. You will still have a penalty if you're under 30 points, but if you have between 7.5 and 30, there's a possibility that it won't be the full 7% negative adjustment to your payments. It could be less. So it's worth it to report, even to get something on the board. If you can get more than 7.5 points, it will help mitigate that negative payment adjustment. Once you get to the 30 performance threshold, that is neutral. So you will not be penalized, but you won't really get an incentive at that level. Between 30 points and 74.99 points is sort of the norm. That's the average. So providers that fall within that scope are not eligible for much, but it's possible you could get some positive adjustment even at between 30 and 75. Again, at the 75-point threshold for 2019, that's what they call exceptional performance. There is a $500 million bonus pool that providers that fall up into that exceptional performance bonus pool area are qualified for. And again, that is spread out among everyone who makes it. so it's not necessarily full 10% or an 8% or a 6%. It's really spread out among everyone who makes it over that threshold. This is what the thresholds have historically looked like and into next year. So the very first year of MIPS, you only had to get over 3 points to avoid a penalty and possibly be qualified for incentives percentages. And the exceptional performance bonus hit at 70 points. And then in year 2, which was 2018, you had to get 15 points to avoid penalties, and then between 15 and 70 points was your neutral zone, and over 70 points, again, the exceptional bonus applied. For this year, 2019, once again, you need to score at least 20 points to avoid the penalty, and then 75 points is now the exceptional bonus level. For 2020, everything goes up again. For 2020, you will have to score 45 points to not incur that 9% penalty. And the exceptional performance level raises to 85 points. So again, this is another view of year 4 of MIPS. The first 2 years were called pilot years. And so this is how things have, as the potential for bonuses and penalties have gone up, the points have gone up, and that 85 points is quite a bit to get into that additional bonus pool for 2020. I like to explain it in this way. I have a lot of clients. We help them with MIPS, and we have, ever since it was Just You prescribed many, many years ago, we've been through Meaningful Use PQRS, and now it's MIPS. I like to explain it this way. I have a lot of clients that they do well with their points, but they don't get the bonus necessarily that they were thinking they should. And this is how I describe it. So the year 1, 2017, it was only 3 points to get over the line, excuse me, and not be penalized. That means the vast majority of people, unless you just did nothing, made it year 1. So the pie was split into very small pieces. And that's why in 2017, maybe you scored a 95%. You weren't going to get a big piece of the pie just because it was split into so many teeny tiny pieces, because almost everyone made it. Excuse me. In 2018, the points raised at that minimum threshold to 15 points. At 15 points, still a lot of people made it, but less than in 2017. So again, in 2018, still very small pieces of pie to split up, but slightly bigger because, you know, less people made it, so the pieces of pie were a little bigger. In 2019, with 30 points being the limit, the expectation is that even less people will make it this year. And again, for those of you who are doing MIPS, that means that those pieces of pie will be bigger for the 2019 exceptional bonus. So that means your bonuses, if you've invested in this program, your bonuses will go up every year. Certainly by next year, when it's 45 points, that is difficult for a lot of practices to achieve. And so those pieces of pie will grow even bigger as you make it into that exceptional bonus pool. Some things that are required both for 2019 and 2020 reporting: you will be required to use full 2015 edition CEHRT software. And I know it's confusing to a lot of people because it's 2019, but these are just versions. The way we have Windows 10, this in Windows 7 and so forth, this is just a version of software. So prior to 2019, we had 2014 software, and in the past 2 years, you were allowed to use 2014 software, 2013 software, a combination of 2014, 2015, and so forth. This year for 2019, you must use the full 2015 edition of your software in order to report. So my first pro tip is to make sure that you can go out onto a website to look at what version you are specifically using and look what level it's certified to. You can also call your software vendor to find out where you're at with the version that you're on. It's very important because if you are not on the version that you need to be on that's fully 2015 edition certified, you're not going to be able to report. So it definitely would be something I recommend you start doing now. If you have to do, particularly we do see sometimes people have to do multiple levels of upgrades and updates to get to the correct version. It also impacts your overall scores, so that if up until this point you looked like you were doing great, you've kind of been looking at your quality measures and in your MIPS dashboard, and it looks like you're doing great, and suddenly you upgrade and all of those quality measures were based on prior year's criteria and it's no longer that way, it can really throw a kink in your plans for reporting and your strategy to move forward with getting enough points. So it is really critical to look at what edition you're on. I also would warn you that historically we see and experience every year a lot of software vendors, and by that I mean your EMR vendors, that wait until very late in the year, sometimes even next year, before they apply some of the updates that really should have been in place during the year. And what happens, unfortunately, is just what I said, only it's very ugly. So you've maybe, planned on these certain quality measures all year that you're using in your system. You have trained all of your providers, the boxes to check, the places to go, your extenders are all doing what they're supposed to be doing, and suddenly they put through a major upgrade or update and it breaks everything, or they put in an upgrade that really should have been there. So this is the way the measures should have been tallied all year, but they weren't because they didn't have the upgrade in place. So when the computer goes back to look at your data, it doesn't count it. So both situations are not good places to be. So I definitely recommend, if you're not sure, call your vendor or check on the CEHRT website to see what version you're on and make sure you're on the most up-to-date version. There are bonuses both for 2019 and again in 2020 for small groups. Small groups are defined as less than 15 providers. That is going to include physicians and extenders such as PAs and nurse practitioners. So there are certain bonuses and lower minimums if you're considered a small group under Medicare. There are also bonuses continuing in 2019 and 2020 for complex patients. And what do I mean by complex patients? Well, this is where I get on my ICD-10 soapbox. Complex patients are defined by the ICD-10 code that is received by Medicare upon billing. So this is the same conversation I've been having with a lot of my clients since 2010, since really the ICD-10 changes took place, and that is if you crossed your regular old ICD-9 codes into generic old ICD-10 codes, and that's all you ever use, you are not going to avail yourself of a complex patient bonus. So you will need to look at that. If you are seeing complex patients, and here in Florida, at least with all the clients I see and talk to, all the doctors I speak with, there's a lot of complex patients. I mean, your 65 plus crowd tend to have multiple chronic conditions, comorbidities, and complications arising. And if that story is not being told in those ICD-10 codes, then you aren't going to qualify for a bonus that you're probably spending your time to earn that you're not getting because you're not telling an appropriately complex story with the right ICD-10 code. And with that, I will step off of my ICD-10 soapbox. Oh, there we go. So to further explain, again, because they just released the Medicare Physician Fee Schedule final rule, I'm able to present this as both the 2019 qualifications and 2020. So this is one thing that didn't change with MIPS between 2019 and 2020. And that is basically in MIPS, there are 4 categories. There's quality, promoting interoperability, which we call PI, improvement activities, or IA, and cost. And again, these are going to remain static from 2019 to 2020. So in 2019, 45% of your total MIPS score, which is 100 points, so 45 points is quality. Quality requires 12 months of data to be submitted at the end of the year. So quality is one of those things that I see, again, updated a lot at the end of the year, and it may get messed up when the computer looks retrospectively. Promoting interoperability, again, will remain the same between 19 and 20. That is 25% of your total MIPS score, which is 25 points. PI only has to be reported for a continuous 90-day period during the year. And it can be any 90-day period. I know that a lot of people will choose the last quarter of the year. Again, I caution you to work closely with your software vendor because sometimes, because they know this, they wait until summer or later to put through certain updates because they're banking on people waiting to do the last quarter, to report the last quarter of the year. So they're thinking it's not that important through the year. But you can report any continuous 90-day period as long as you define it when you do your attestation. Improvement activities are 15% of the total MIPS score, or 15 points. Those also are attested to a continuous 90-day period. So what that means for us today is it's the first week of November, the 5th, I believe, and that means that our 90-day period for both promoting interoperability and improvement activities has already begun. When you get to attestation, you will have specific scores from your system for PI. IA is something that you attest to, yes or no. I understand that it can be tempting to say yes to certain things. However, I will caution you that on audit, they will ask for verification that you were doing what you said you were doing during the period. And so one of the things that we do when we assist with MIPS or with MIPS reporting and attestation is we try to create a virtual folder. So, gone are the days of the big binders, but some people still like them and we're fine with that. So we try to do it in PDF, but we create a binder of all of the backup documents that we know that you're going to need should you ever be audited. And we do that because we've been through enough audits and because we are called in to assist in helping people defend themselves during an audit. There are 2 basic types of audits that can happen with quality, PI and IA. That is, you can have a pre-adjudication audit. So you can send all your attestation in, and before they make a determination about your level, they can go ahead and ask for those records and audit you. The other type is later, so they can go ahead and make that determination and then come back in and say, wait a second, we want to see these records. We do see that a lot with people. If you've had an audit and you've failed an audit, then it is highly likely you're going to be audited again, obviously. But we do see that quite a bit. And one of the things that we're on the call about today is the SRA, the security risk analysis, along with training and other things that need to be done and you need to document. And that is one of the areas that's sort of low-hanging fruit that they can trip you up on if you don't have those things completed and signed off properly and documented properly. So those are the three big things that practices have control over, a lot of control over, is the quality, PI, and IA. Cost is the fourth part of the MIPS score. It is 15% of the MIPS score. It is based on 12 months of data. Again, that will stay the same between 2019 and 2020. You don't personally do anything or submit anything for cost. Medicare does this determination automatically through the claims data that you submit. You do have some control over it, and it is interesting if you look at the way the trajectory of healthcare and where we're headed, and you look at your cost data, it is interesting to see where you fall in the grand scheme of same specialty. You know, are your costs higher? Are they lower than average? Obviously, the lower per average your costs are, the higher your score is going to be for the MIPS cost score. But it is interesting to see where they fall. And so ultimately, you may have some control over that if your costs are higher than average because, you know, you're running more tests or things. I mean, those are all decisions you can make, and I don't make clinical decisions for anyone, but they're good data to have and to look at so that you understand how these all of these factors factor into the 100 points of MIPS, which ultimately is your final score and ultimately will be the way you get a raise from Medicare. So how to avoid penalties. So for quality, again, it's a 360-day reporting period. There's a total of 45 points possible. That stays the same for 19 and 20. You choose up to 6 measures and report on more than 60% of all qualified Medicare patients for each measure. So what exactly does that mean? That means if you choose a measure that has an ICD-10 code or codes associated with it, that of all of the patients you bill to Medicare, you're going to report at least 60% of the ones that fall into the measure. So you can't just pick and, you know, cherry pick certain ones. You have to do at least 60%. The same with CPT codes or other qualifiers. So if your patients qualify for those measures, you're going to have to report on at least 60% of those patients to Medicare. For each measure, you have to have at least 20 patients in the denominator. So if you have less than 20 patients in the denominator, it's not a reportable measure. You are required to have at least one high priority measure in your set when you report. And those are identified on the QPP website, and you can see what the high priority measures are. There are certain exceptions, and depending on your specialty, that you might be able to report other measures, but you do want to, if at all possible, report at least one high priority measure unless you clearly fall within an exemption. There are 3 to 10 points possible for each measure. And why 3 to 10? Well, depending on the measures that you choose, if you choose measures that don't have historical data, those are only going to be worth a maximum of 3 points. If you choose measures that have historical data, then there's a whole host of things. We'll talk about a couple of them on the next slide that play into how many points ultimately you're going to get. Now, I know this doesn't make sense because if you were to get a total of 10 points on 6 measures, that's 60 points, but I've told you that quality is only worth 45 points. And you're right, it doesn't make sense unless you dive deep into some high school algebra. But basically, your 60 points translate as a ratio, there were 70% each, if you will, into 45 MIPS points. So that's, in a very simplistic way, how that all happens. But if you were to get a perfect score on each of 6 measures, you would get 45 MIPS points. So that's how we have formulas built into the spreadsheets that we do. That's why I can tell you so much about them, but that's how that works. And here is an example of the differentials that you can have within even the same measure. So, for example, if you were to pick flu shots, flu vaccines as one of your measures, let's say it's something that's built into your system and you're going to use that. Depending on how you report, so if you look at the second column there, it says submission method. So we have three basic submission methods. We have claims, we have registries or QCDRs, and we have EHR. Depending on how you report, in part weighs how many points your score is worth. Basically, historically, what has happened is because claims was the first way to report, and it's been reported that way the longest, it also is the most prone to, how do I say, overestimation. So if you're reporting claims-based, you are self-reporting that you did these things within your EMR chart. And what they found was on the claims-based self-report method, most people, most of the time, said yes, they did everything. So what has happened over time is those deciles, which is the ranges at which you earned certain points, have grouped all up into the very, very high range, because historically people who have claims reported have self-reported that they did almost all of these things almost all of the time. So in my example here, let's say you got 68% for your score on flu vaccine. If you were claims reporting, that 68%, which I've got there at the top right, if you look at where that falls into the deciles for claims, that's going to fall into decile 5. So you would get 5 points and change for a 68% if you were claims reporting. On the other hand, if you're registry reporting, apparently people are more honest, I don't know, when reporting to a registry. This also includes people who upload data, so who extract tables out of their system and upload directly. So they don't self-report as high in numbers on registry and QCDR. There's some electronic transference of records happening. So those numbers aren't quite at the same level. So your 68%, if you look on the bottom row for registry, your 68% is going to earn you in the decile of 6. So just by doing registry instead of claims, you're going to earn more points. On the top row, and this is how we structure all of our clients to do their reporting wherever possible, is to use their EHR. It's not always ideal, but it's beneficial. It's the most beneficial. If you see when you report EHR, the scores have a tendency to be lower, so the averages are lower. So you're graded on a curve, if you will. So what that means is that same 68% quality measure meet score is now equated all the way up into the 9th decile. So just by reporting directly through your EHR, EMR, you're almost doubling your points on just this example measure. So that's the basics of quality, and then we want to move on. That's, like I said, to keep in mind, to avoid penalties, you have to have 30 points this year. So if you had enough points just in quality, you could just do quality measures, totaling up to 30 points, and avoid penalties. If you can't get enough, let's say you didn't start soon enough, or you just don't have enough things that apply to you, for whatever reason you can't scrub enough points out of quality. And in fact, if you were to even report minimal quality across six measures, you're still not even going to get 15 points total MIPS points out of quality. So if it didn't work out for you on quality, then we still have PI, promoting interoperability. Now, this used to be called meaningful use, so it's the artist formerly known as meaningful use. But this is another place where you're able to earn 25 points. Again, PI is a 90-day reporting period versus 365. And it does require you to report on 4 minimum objectives. And if you don't meet one of those 4 things, you get a 0. There's no kind of sort of like with quality, you can report on less than 6 and still get some points. With this, there's a little bit of all or none to it. And again, I mentioned before, and this is why Compliancy Group and we have partnered to help you meet all of the criteria, because you have to do a security risk analysis in order to qualify. That's one of the qualifiers. So if you don't do that, you get 0 points for the out of the 25 PI points possible. And what are those things that you must do? One of them is e-prescribe. So you have to hit that, and you have to hit it at least once, but it's also worth points based on your score. When it was meaningful use, it was based on whether or not you did it. It wasn't based on the score. But now under MIPS, it's required that you hit it at least once, and you get a score based on the total percentage that you earn. So if you earn 94 percentage on e-prescribe, you would get 10 points. If you only earned 30% on e-prescribe, you would only have 3 points. So it's both required and it's a performance measure. We have a couple of bonus points available if you're using a PDMP, a prescription drug monitoring program. Here in Florida, we have eForce, which I know those of you that I've helped with MIPS, that's one of the things that we do. But it's a good idea whether you're claiming it or not, but it will get you bonus points, as well as for 2019, we have the verification of an opioid treatment agreement can also get you bonus points. The second thing that you must do is HIE, and that is for 2019 and 2020, you have to both send and receive HIE in HL7 format so that it can be integrated directly into your EMR. Every certified EMR has to have this capability in order to be certified. So when I run into people who say, but I can't do, nobody's doing this, I'm like, well, if they have a certified EMR, they have to have the capability to do it. Whether they're doing it or not is not under my control, but their certified EMR does have the capability, and in order to meet PI and get any points of the 25, you do have to send and receive at least one. You also get points the more you actually do. So it, again, is a two-edged sword. You have to meet it and do well in it to maximize your points. You also have to have the patient portal up and running, and patients have to be getting, that's number 3, they have to be getting access to the portal. Doesn't mean they actually get on, but as long as you're doing what's necessary within your system, which is typically getting the email invite out to them, then that would qualify. Again, both a required measure in order to earn any of the 25 PI points, and a measure that you get more points the better that you do. And then lastly, we have the registry reporting, which is required unless you qualify for an exemption. If you qualify for an exemption, those 10 points are redistributed above. But if you don't qualify for an exemption, then you have to do certain types of registry reporting. There are certain types of providers who are automatically exempt from doing what used to be meaningful use, or PI. And these all have certain, we don't have time to go in depth today, but they all have certain requirements. So if you're hospital-based, non-patient phase, so if you're hospitalist, if you're like radiology or pathology, if you're a nurse practitioner or a physician assistant, a CNS, a nurse anesthetist, if you're surgery center-based, if you're a therapist, if you're an audiologist, a psychologist, or a nutrition professional, those are all exempt from PI, just the PI, and their 25 PI points are reweighted to quality. So they have 70 quality points instead of 45. And that just makes it all the more important what they do with quality. So they don't just go away. You're not just exempt from them. They move over into another area. And if you still do poorly in, the quality, you're still not going to get the points that you possibly could. There are also exemption applications available if you fall, and they are true exemptions. You can see them here on the screen. Insufficient internet, extreme uncontrollable circumstances, which we had with the hurricane here, Irma in 2017. If your EHR was decertified during the year, so there is a hardship exemption for small practices, but you really want to take a look to see if you qualify for that. And again, this isn't the be-all, end-all. It doesn't mean those 25 points go away. It means they go over to your quality. So be careful what you wish for if you take these exemptions, because then everything hangs on your quality scores. And then we have improvement activities, or IA, that is 15 points of your final score. Again, if you, in order to, so we looked at quality, which could be 45 points. If you do minimal on there, you might be able to get about 14 points. We looked at PI, which is 25 points. So you can't get 30 just doing that, but if you combine it with enough quality points, you still might be able to get to 30. If that still hasn't gotten it and you go to improvement activities, this can be a more efficient way to get to 30 points. You can't get there just here because it's only worth 15, but it's an add-on. If you're a small practice, if you're in a HIPSA, if you're non-patient facing, then you can do either 2 medium-weighted activities or 1 high-weighted activity to get your 15 IA points. If you're a large practice, meaning you have 15 or more providers in your group, then you would have to do 4 medium-weighted activities or 2 high-weighted activities in order to earn that 15 points. And again, this is an attestation. I just want to remind you to make sure that you back it up with documentation that shows what you said you did in case you're audited. And I want to remind you, this is a 90-day performance period on improvement activity. So if you started something in the last month, you're able to report it for the end of the year. So again, if you haven't started, it's possible to still report. You want to, really what I would recommend you do is contact your EMR vendor to be able to make sure that you're up to date on all of your software, all of your versions. You've got the 15 version of your CERHT software. And then once you're sure you're all up to date, have them assist you with running a MIPS dashboard with, and I the first time run it wide open. So we run it wide open just to see what you might be hitting and what comes up. And then we go from there. So if you have 6 quality measures that have at least 20 patients in them, that you really are doing whatever the quality measure requires, then you could, even if you're ophthalmology and you're doing flu shots, I mean, there's not a requirement on the quality measures, but you'll want to take a look at them and make sure it's things you're actually doing and you have enough patients in the denominator to be reportable. And then your improvement activities, we find a lot of times I have real life definitions. So the government puts out the legalese and we have sort of real life definitions by specialty. And so we can look and see maybe there's things that you are currently engaged in that are reportable and logistically documentable and reportable for at least 90 days during the year. So things that are required as we run into the end of the year here, I know it's getting busy. We're getting into season and we're getting into holiday season. So there's a lot required between now and the end of the year, which is less than 60 days. I know it's hard to believe. Medicare, if you take Medicare at all, of course, they require billing, coding, fraud, waste, and abuse, and HIPAA compliance training. These types of training are required within 90 days of initial hiring and annually thereafter, along with your OSHA training. These are all things that as we have built up our online training portal that we have added. So for low cost, sort of at home or lunchtime training without having to shut your practice down, these are the kinds of things that we're building into our online training portal. These are all required for both Medicare as a medical practice and before you do your MIPS attestation. So when you go to do your MIPS attestation, along with just general HIPAA regulations, it requires you to do a security risk assessment each year. And so, you have a lot of options. The security risk assessment is really complex, and you may have done them and may be familiar with them, but to really do them, especially in these days of hackers and people who fool your front desk and who fool your doctors, and none of us are beyond being fooled by some of these ploys that they play, along with the fact that healthcare doesn't tend to be the most secure. That's not high up on the list. They don't tend to have a lot of on-site IT that can ensure the high level of security that HIPAA requires. So it is critical to do these things to protect your practice. All providers participating in Medicare and Medicaid incentive programs, which includes MIPS, APMs, are required to do that yearly security risk analysis. And so if you need, full service attention, that's where I will pull in Liam here in just a moment. So basically, to finalize MIPS is just help is a call away. You're welcome to call us. Again, 30 points this year to avoid penalties, at least 70 points to start earning some significant bonuses. And I wish you all the best of luck. Call us if you have any questions or need any assistance. And now Liam is going to talk about the security risk assessment.
Awesome. Thank you so much for that, Belinda. I'm just checking the question box real quick to see if we've got anything. And doesn't look like there are any specific questions. Let me just real quick make myself the presenter if it's going to allow me to do that. All right. There we go. All right. So to very briefly hit on for everybody, the overall, this is of course the much broader HIPAA risk assessment requirement. So this is something that you should be doing anyway from a HIPAA perspective, okay, if just for your annual HIPAA compliance programs, all right? But specifically, just for the purposes of today's webinar highlighting MIPS, this is not only something that's required under the HIPAA laws, it's something that can help you out just from the perspective of that MIPS attestation, okay? And so what many people misunderstand about things like their security risk assessment, okay? The technical term under HIPAA is a security risk analysis, okay? And so oftentimes we find that people are doing some form of an assessment, but it's often just these, what you see as these two technical audits that are here up at the top, okay, specifically related to their IT. Okay, now the actual annual assessment requirement in order for that attestation, okay, and in order for your HIPAA compliance programs, okay, it's actually a series of 6 individual audits that make up that full assessment, not just addressing things like your IT, okay, but also addressing your physical security, things like policy, procedure, training, operations within the practice. What we would be doing as a company is very simply just looking to keep this as simple as possible with you, okay, give you a very streamlined and simplified way to be able to manage this effectively. And the ultimate goal of that is to bring you from a position where we're addressing what is the full extent of this regulation, but then also putting you in a spot where it's all tracked much more effectively, because in order for you to be fully HIPAA compliant, it's a matter of doing that assessment, figuring out where your gaps are, remediating them, putting in place policy and procedure, right? Training the staff, which is some of the things that Belinda had mentioned, executing the right types of agreements. We find that healthcare, by and large, is the most vulnerable industry to cyber risk, even if we take into account things like ransomware. 88% of ransomware is perpetrated against a small to mid-sized healthcare entity. Okay, so this is not only something that's going to help you out big time from a MIPS perspective, it's something that is going to protect your practice in the broader sense, just from being HIPAA compliant and overall just help you operate in a more profitable way. All right, so that's just to give you a little bit about us. Those assessments, everything that we talked about on the webinar today, again, it is going to be recorded. So if you would like that recording, feel free to reach out to either myself or Belinda. Any questions at all from a HIPAA perspective, you can reach out to me, and also Belinda's contact information was on the screen just prior. So Belinda, anything else you would like to add before we conclude the webinar for today?
No, I just want to say thank you again to everyone for your time. Best of luck with 2019 and 2020 MIPS, and I hope everybody stays safe from, hackers and otherwise. But certainly reach out to us. We're here as a resource.
Fantastic. Thank you again, everybody, for attending. If you need anything, again, feel free to reach out. Belinda, thank you so much for being on the webinar with us today. Your expertise is more than appreciated. All right.
Thank you. Take care.
All right.